Hi there, I'm Steve Chadban from Sydney, and on behalf of the Steering Committee of CARSK, thanks for joining us on today's webinar. We thought it would be a good time to pause and reflect on the whole reason we're doing the CARSK trial, particularly in light of the recent publication of the ischemia-CKD trial. And to help us do that today, we're really fortunate to have two fantastic cardiologists. Chuck Herzog from the US is going to talk about the data or the lack of data that underpins the rationale for doing CARSK. And then PJ Devereaux from Canada, who's an extremely experienced clinical trialist, is going to talk us through his interpretation of the results of ischemia-CKD and tell us what he thinks that means in terms of the importance of doing the CARSK trial. Without further ado then, I'll hand you over to Chuck and PJ, and then I'll rejoin you at the end and see what your conclusions are. Thanks, Chuck.
Hello, my name is Chuck Herzog, and I'm part of the CARSK steering committee. I'd like to spend a few minutes talking about the background and rationale for the design of the CARSK trial. These are my financial disclosures. And the title of my mini lecture is Surveillance Cardiac Stress Testing in Waitlisted Renal Transplant Candidates Evidence-Based? A Compelling Rationale for the CARSK Trial. So I was one of the investigators in the ischemia-CKD trial, which Professor Devereaux will discuss in a few minutes. Ischemia-CKD, or the International Study of Comparative Health Effectiveness with Medical and Invasive Approaches to Chronic Kidney Disease trial, was an international trial sponsored by the National Heart and Blood Institute of National Institutes of Health. And it does provide a compelling basis for the part of the background rationale for doing the CARSK trial as well. So there were several studies that evaluated the impact of revascularization on outcome prior to non-cardiac surgery. And we would include renal transplantation as a type, obviously, of non-cardiac surgery, even though none of these other trials dealt with this special population. Probably the best known trial was CARP, coronary artery revascularization before elective major vascular surgery. My old friend and colleague at the Minneapolis VA, Ed McFalls, was the PI for the CARP trial. And this was a trial of patients who were destined to have major vascular surgery and then were evaluated and either received no coronary revascularization or they did receive revascularization. And interestingly, this is quite a high-risk group because a third of the patients in CARP actually had three-vessel coronary disease. So this was really a real high-risk population for outcomes related to ischemic disease. As you can see in the Kaplan-Meier figure, looking at the survival after the two arms, there's absolutely no difference between the two groups. The survival curves are almost superimposable. So first attempt, a relatively small but well-designed trial with very good medical therapy in each arm, no suggestion of benefit for preemptive revascularization before major elective vascular surgery. Another study that was published several years later was the DECREASE-5 pilot study that also looked at patients with extensive stress-induced ischemia. About half of them had angina, and as you can see from the Kaplan-Meier curves, certainly nothing to suggest a benefit of revascularization compared to medical therapy. If anything, the trend was in the other way, but certainly no suggestion of really any benefit comparing medical therapy to revascularization. So the conclusion from these two trials, even though they were both relatively small, is that preoperative coronary revascularization in high-risk patients was not associated with an improved outcome. Which brings us to our special population of interest, those who are candidates for renal transplantation. And going forward a few years after these trials were published, The American Heart Association, in conjunction with the American College of Cardiology Foundation, published a scientific statement that was endorsed by AHA, ACC, the American Society of Transplant Surgeons, American Society of Transplantation, and the National Kidney Foundation. And the work group, which was studying cardiac disease evaluation and management among kidney and liver transplantation candidates, the liver part was about 2% of the document, 98% of it was on kidney patients. The overall conclusion was there was no benefit to support prophylactic preoperative percutaneous revascularization in patients with asymptomatic ischemia or stable angina. We'll get back to that, more specific examples from the scientific statement, but this essentially is the compelling rationale for ischemia-CKD. It really provided clinical equipoise for the ischemia-CKD trial. And it's also really the part of the background to understand the rationale for CARSK as well. It's worth considering what the World Health Organization says about who and why patients should be screened for diseases. For public health impact, the condition should be an important health problem. We should have an understanding of the natural history of disease, and there should be a latent stage for detection and intervention. There should be a test for the disease, and this test should be acceptable to the population being tested. And case finding should be a continuous process over time. There should be a treatment for the disease, and we should have some idea about who to treat and facilities for treatment to accomplish this treatment. And finally, there should be some element of cost effectiveness, so the total cost of finding a case should be economically balanced in relation to medical expenditures as a whole. So in terms of the background current standard of care, and this is obviously a moving target, but still pretty much true even several years into CARSK, if we look at practice in the United States and Canada and the European Union, standard of care does involve screening for coronary artery disease in renal transplant candidates, both prior to acceptance onto the waiting list and at regular intervals after waitlisting. The aim of screening is to identify coronary artery disease by non-invasive testing in most centers, to identify critical coronary stenoses by angiography, and prophylactically to revascularize patients with obstructive coronary disease. Now, where did these guidelines come from? Because they are actually a little bit at variance with general societal guidelines in the general population. So the origin, we have the AST 2001 guidelines that basically recommended screening in medium or high risk patients. Typically, these would be patients with diabetic nephropathy as cause of end-stage renal disease, or prior history of ischemic heart disease, including MI or known coronary disease by angiography, or just two or more traditional risk factors. And the intent was to detect disease, find critical lesions, and revascularize. AST, about a year later, had a special consensus conference on waitlist management. And I was a participant in that conference, and we did recommend surveillance screening for people who were waitlisted based on level of perceived risk, the highest risk group being patients with incomplete revascularization in the past, or with diabetic nephropathy. And an annual rescreening was recommended. KDOQI 2005 guidelines are the only guidelines that were ever published specifically dealing with cardiovascular disease management in dialysis patients. And in KDOQI, we recommended annual stress tests in waitlisted patients who have either diabetes, a history of ischemic heart disease, peripheral arterial disease or ejection fraction less than 40, or greater than two or more traditional risk factors. These waitlist screening guidelines, surveillance guidelines, perfectly matched the AST waitlist conference guidelines. But unfortunately, or to understand why that is, there was a common thread between these two conferences, which is that I was a participant in both. And sad to say, 20 years ago or 15 years ago, we didn't have a lot of information to go on, so we took our best stab at opinion-based guidelines. And these two early attempts are essentially the same, and neither of them were really evidence-based, but that was about the best we had 15 to 20 years ago. Now, more recently, if you look at the concordance or discordance of guidelines, it tells an interesting story. I just talked about AST and KDOQI, and then several years after that, the American Heart Association and the American College of Cardiology published guidelines on preoperative risk management. Patients with intermediate risk surgery, whom patients undergoing renal transplantation would fall, patients with greater than 1 risk factor and no symptoms, and a functional capacity of greater than equal to 4 METs. Those patients, the recommendation was just proceed directly to surgery and don't do any type of screening. And if the patients were unable to walk, and so they couldn't have functional capacity assessed, or if they had unknown symptomatology, then surgery with heart rate management, specifically intraoperative beta blockade, and stress testing was recommended if it will change management. This was a class 2B recommendation, so very weak class of evidence. 10 years later, the Canadian societal guidelines basically took issue with these other 3 and made a recommendation against performing any type of perioperative echocardiography, either exercise stress testing, pharmacological, or stress echocardiography, or preoperative radionuclide imaging to enhance perioperative cardiac risk estimate or estimation. So this was basically a no guideline recommendation. So we have sort of the spread of recommendations to do or not do things, which is about the best you're going to ever have for equipoise for designing anything, which is that not anybody seems to agree on much of anything. And the reason, of course, is there wasn't much of evidence to agree or disagree on anything. Which brings me back to the AHA-ACC expert consensus document. So this was a mixed group of cardiologists, nephrologists. They did a deep dive into what the evidence was. I did not participate in the guidelines directly, but I was a peer reviewer, so I was looking at this from a perspective of a reviewer rather than as an author. So there was a strong rationale, and there continues to be a strong rationale for a CAD screening trial in waitlisted patients. The need for evidence to guide waitlist management has never been greater. The evidence in the non-transplant setting suggests that investigation or intervention is actually unnecessary, but perhaps there are unique considerations in patients with end-stage kidney disease that make extrapolation more difficult. So the argument has been that perhaps the transplant population makes extrapolation from non-transplant settings difficult. And there are a number of reasons to say that. One of them being that there's always going to be a shortage of organs for patients waiting for deceased donor transplants. So perhaps there was an argument that this would be something to as a resource allocation strategy to make sure that we have the best potential recipients for a scarce resource. A study on waitlist management should address our clinical needs, which means excluding poor transplant candidates, decreasing the likelihood of death on the transplant waitlist, surviving the perioperative period, and hopefully improving long-term post-transplant outcomes. So these are the 4 compelling clinical things that we have to worry about in for coronary disease management waitlist candidates. It's clear that we ideally would have studies to assess the entire waitlist strategy, not just revascularization. So then the question comes up is, well, why is it ethical to do a screening trial? Remember, I mentioned that there were certain sites that refused to participate in ischemia-CKD because they said, well, we just can't do this because we can't have patients randomized in a study like ischemia-CKD. So what about a study like CARSK, where we're talking about waitlist screening? And I think the appropriate response is that the strategy of testing and intervention is not risk-free and actually may be harmful. Patients who, not everybody who is a transplant candidate has no renal function, so there's certainly a concern about loss of residual renal function with angiography. In the US, like in my own center, we have patients who are not even on dialysis who are waitlisted. So there, the risk of contrast nephropathy is not inconsiderable. If you look at revascularization outcomes historically and from observational studies, the risk of in-hospital mortality following surgical coronary revascularization, at least, it's about 3 times higher in dialysis patients than those without end-stage renal disease. So this is not a low-risk intervention by any stretch of the imagination. There's also the risk of blood transfusion and stroke in patients on dialysis in the setting of revascularization, or even angiography occasionally. And then abnormal screening tests may have the unwanted effect of unnecessarily delaying transplantation or even potentially excluding patients from consideration of transplantation. If a screening test has the effect of delaying transplantation and is actually not a benefit to the patient, that's definitely not an optimal result for the patient community who are waiting for transplants. The hypothesis of CARSK is that after screening for waitlist entry, non-use of cardiac screening tests is non-inferior versus the current standard of care, which is screening all asymptomatic waitlisted patients for coronary artery disease at regular intervals. CARSK will also compare the benefits and costs of screening and subsequent treatment versus not screening from a health system perspective. I'm sure you're all familiar with the CARSK trial design. Just to remind everyone who's on the webinar, patients at least 18 years of age with no symptoms of active cardiac disease, patients who are waitlisted only for kidney transplantation, no previous extrarenal transplant. The anticipated date of transplantation is at least 12 months from the date of enrollment, and that these potential subjects for CARSK would have required cardiac screening before transplantation if they had not been enrolled in the trial. Subjects that are randomized to the conventional arm will receive the usual protocol waitlist screening that would be followed at each site. Typically, that would be annual surveillance from the date of the last screening test in patients with diabetic nephropathy, incomplete revascularization, or coronary bypass surgery done more than 3 years ago, but we would defer to whatever the site's normal practice is. And then in the intermediate group, every 24 months for all others, again, per site protocol. In the non-screening arm, which is the experimental arm, patients would not receive routine surveillance, but the sites would always have the option of doing stress tests or angiography in patients that developed new symptoms, or if there were a compelling clinical indication for doing cardiac evaluation, which is based on patient management from each site investigator. One question that comes up is, then why didn't we also design the trial to test the hypothesis of whether any screening should be done, not just waitlist management? And there are a couple of reasons for this. The primary reason was that in initial surveys for CARSK design, there was not a general agreement to forgo initial cardiac evaluation. And this same issue came up a number of years earlier in another trial that was being designed by Bert Kosiski. And the fact is that there is not a general consensus anywhere that physicians involved in the care of these patients would be, at this time, would be willing to forgo initial cardiac evaluation. Now, I believe a case could be made also not to do initial cardiac evaluation, but if we had gone that route, we wouldn't be doing a trial on anything at this time. So we had to acknowledge the reality that there is not acknowledged to be equipoise in this particular area by the clinical community. And for this reason, as there is clinical equipoise around the use of screening after waitlisting, that is what informs the CARSK trial design. The second point is that in terms of the largest health services impact, it really is related to the use of multiple screening testing during the often prolonged time of waitlisting, which could be anywhere in the 2 to 8 year period of time. An average waitlist time of 4 years is not unusual for many transplant centers. So if we're looking at the cost of health services utilization, a trial that is designed to deal with multiple testing will ultimately have more of an impact on this issue than just one involving single test. So this is another reason why CARSK, I believe, is well positioned to deal with this issue of, to focus on waitlist surveillance rather than initial waitlist management. The CARSK is an exceedingly important trial that will affect clinical management and patient care worldwide. This is not a trial that will ever be done again in the near future, just as ischemia-CKD is unlikely to be replicated, at least in my professional lifetime. I'm sure the same thing can be said about CARSK. So I think it's a lot of effort to get this trial finished. I think it's well worth the trouble. And I think that the importance of the CARSK trial to patient care cannot be overstated. And with that, I'd like to turn the next session of the webinar to my colleague, Professor Devereaux, who's going to be talking about the results of ischemia-CKD.
Hi, I'm Dr. PJ Devereaux. I'm a cardiologist and perioperative care physician at McMaster University, and I'm the director of the Division of Perioperative Care at this institution in Hamilton, Ontario, Canada. I'm expected to put up my disclosures as part of our institution policy. I'm a member of a research group which has a policy of not accepting honorariums or payments from industry for our own personal financial gain. We do, however, accept honorariums or payments from industry to support research endeavors and costs to participate in meetings. And based on study questions I've originated and grants I have written, I've received grants from the companies that are listed here, and I've also participated in advisory board meetings and expert panel meetings for the companies that are listed here. The objectives of my talk is that I'm going to talk about the design and the results of the ischemia-CKD trial. The background of this trial is that clinical trials in patients with coronary artery disease that have assessed the effects of coronary vascularization have excluded patients with CKD, and this trial was undertaken to fill this gap. The ischemia-CKD design was that this was an international randomized controlled trial of 777 patients with advanced kidney disease and moderate to severe ischemia. The setting for this trial was 118 centers in 30 countries. The eligibility criteria was that patients had to have an eGFR less than 30 or be on dialysis, and patients also had to have moderate to severe myocardial ischemia on cardiac stress imaging. Patients were randomized to an initial invasive strategy, which consisted of coronary angiography and coronary artery vascularization, if appropriate, and medical therapy. Or alternatively, patients were randomized to the control group, which was an initial conservative strategy of medical therapy alone, and then patients could undergo angiography if medical therapy failed. The primary endpoint was death or non-fatal MI, and this was designed as a superiority trial. And the follow-up was a mean of 2.2 years, and just 1% of the patients were lost to follow-up. The baseline characteristics is that the mean age of participants was 63 years of age, 53% were receiving dialysis, and among the patients who were not receiving dialysis, the median eGFR was 23. just under 60% of patients had diabetes, just over a third of patients had severe ischemia on their stress imaging, and just over 40% of patients had a Canadian Cardiovascular Society class 2 or 3 angina. This slide shows you the 3-year cumulative incidence of cardiac catheterization. And as you can see here, 85% of patients in the invasive group underwent cardiac catheterization, and 32% of patients in the conservative group underwent cardiac catheterization. Also importantly, in the invasive group, cardiac catheterization almost happened immediately after randomization, whereas in the conservative group, the cardiac catheterization happened across time of the 3 years. Looking at the cumulative incidence of coronary artery revascularization, this slide shows you that 50% of patients in the invasive group underwent coronary artery revascularization, whereas 20% underwent coronary artery revascularization in the conservative group. And again, you can see in the slide that in the invasive group, the revascularization happened very quickly after randomization, whereas in the conservative group, this happened relatively consistently across the 3-year follow-up. The reasons for cardiac cath or revascularization in the conservative group was that this was due to a confirmed event in about a third of the patients and a suspected but not confirmed event in another third of patients. And only a third of the time when patients underwent cardiac cath or revascularization in the conservative group was this due to non-adherence of the protocol. This slide shows you the results for the primary endpoint of death or non-fatal MI. And this shows you that there was no difference between the invasive and the conservative strategies. The hazard ratio was 1.01, and the 95% confidence limit went from 0.79 to 1.29 with a p-value of 0.95. There was, however, an increased risk of stroke in the invasive group, and the hazard ratio was almost a 4-fold increase in a result that was highly statistically significant. Also, there was an increased risk of death or initiation of dialysis in those who were not on dialysis at baseline. The hazard ratio was 1.48, and the p-value was 0.02. And as you can see in this picture here, there's almost an immediate increased risk of death or initiation of dialysis in the invasive group. And after almost 3 years from the time of randomization, these two curves come back together. And this is likely explained by the fact that initial cardiac cath and revascularization increases the probability of new dialysis, but over time, the patients in the conservative group who are destined for dialysis eventually catch up. And this slide just shows you the results for new dialysis, which is what drove the signal in the last slide, looking at death or new dialysis. And again, immediately you see the substantial increase in new dialysis amongst patients randomized to the invasive group compared to the control group. And after about 3 years, the curves come back together. So again, if you don't undergo the invasive strategy, you will delay the time to dialysis in your patients. So in conclusion, among patients with stable coronary artery disease, advanced chronic kidney disease, and moderate to severe myocardial ischemia, initial invasive strategy was not beneficial and was associated with harm. These trial results are very important for clinical practice. Also, they highlight the importance of the trial looking at whether or not we should be doing systematic screening for coronary artery disease in patients with CKD who are awaiting transplant, as opposed to only going with a more conservative approach and evaluating patients who demonstrate ongoing problems with symptoms. I do thank you very much.
Hi there, it's Steve Chadban again. Thanks for watching the webinar. I hope you found it really interesting. I certainly did. I think that Chuck paints a beautiful picture describing why we needed to design and undertake CARSK. And I think that PJ really provided the key reason that we need to follow through and complete this trial in light of the findings of ischemia-CKD. The signal of potential harm associated with intervention in CKD is one that really resonates with us as clinicians. CARSK is now really well underway across the world, really, with active centres in Europe, centres right across Canada, down into the US, and very active trial centres across Australia and New Zealand. We're really delighted that you can join with us. We really want to finish this trial, and it's great to have you on board. I'm now going to throw back to your local chairperson, and we'd love to hear what your discussion about CARSK brings forward. On behalf of the steering committee, particularly John Gill in Canada, and myself and the team here in Australia and New Zealand, we'd love to hear your thoughts on CARSK, where it's going, and what role you'd like to play in pursuing this important trial. Thanks very much for joining us today.